Assalamu alaikum, I'm Dr. Sidra Arshad, and today I shall be talking about the hormonal regulation of calcium and phosphate metabolism. This is the sixth lecture in the series of endocrine physiology, and it is going to be divided into these three sections in this lecture. In section 1, I shall be talking about the calcium and phosphate regulation in ECF and plasma. I'll start off by overviewing the calcium and phosphate distribution in the body, and then what are the consequences of altered calcium and phosphate concentrations in the body fluid, especially the non-bone consequences. A brief overview of bone physiology and its relationship to ECF, calcium, and phosphate is going to be discussed. In the next section, the sole focus will be on the hormonal regulation of calcium and phosphate. The three major hormones will be discussed in a little bit of detail. That is parathyroid hormone, vitamin D, and calcitonin. Then we'll finish off by discussing the abnormalities of parathyroid hormone and vitamin D. These abnormalities are going to include hyperparathyroidism and hypoparathyroidism, rickets, and osteomalacia. So let's start with the calcium and phosphate regulation in ECF and plasma. If we talk about body calcium, it is distributed into the body fluid compartments in such a way that 99% of total calcium it is found in the bone. It is found in the bone mostly as complex calcium phosphate salts, which are known as hydroxyapatite crystals. The calcium which is not present in the bone, it is present in the rest of the body compartments, that is in the interstitial fluid, intracellular fluid, and plasma. So 1% of the total calcium which is not present in the bone, it is found in the intracellular fluid. 0.1% of total calcium is found in the interstitial fluid, and this form of the calcium is mostly existing as ionized calcium or calcium ions. In the intracellular fluid, the calcium, it exists as ionized form and also bound to certain proteins. While in the plasma, less than 0.5% of total calcium is found. Half of it exists as ionized calcium or free calcium, and the levels of these free calcium ions have to be tightly regulated. 40% of the calcium is bound to protein, and 10% is complex to anions, for example, phosphate and citrate. So this is the distribution of body calcium. We are going to see it in a little bit of detail. So 98.9% of total body calcium, it exists in bones. 1% of total body calcium, it exists in the intracellular compartment. It is present inside of the cells in both ionized and protein-bound forms. 0.1% of total body calcium, it is found in the ECF, mostly in the interstitial fluid. This calcium concentration is maintained at about 9.4 milligrams per deciliter or 2.4 millimoles per liter. So this calcium concentration is tightly regulated. Protein-bound calcium exists in the plasma. 41% of the total calcium in the plasma is bound to protein. Then ionized calcium, 50% of the ionized calcium exists in the plasma, and this is also known as free calcium or the calcium which has to be regulated. Calcium is also complex to anions present in the plasma, for example, phosphates, and this form of calcium, it occupies 9% of the total body 9% of the total plasma calcium. Concentration of calcium is also affected by pH. If there is alkalosis or pH is increased, there is more protein-bound calcium. More of the calcium is bound to the protein, so free calcium levels are decreased when the pH is high. On the other hand, if the pH is low or there is acidosis, less protein-bound calcium is there, and because of that, the free calcium is actually increased. As far as phosphate is concerned, 85% of total body phosphate exists in the bones. 14 to 15% of total body phosphate is intracellular, and less than 1% of total body phosphate is found in the ECF. In the ECF, phosphate exists in two forms. It exists either as dibasic phosphate and dihydrogen phosphate. So it exists in two forms, dibasic phosphate and dihydrogen phosphate. Now these values that you see over here, these are obviously not constant because the presence of these two anions, they depend upon the pH status of the body. If the pH is acidic, the pH of the ECF is acidic, the phosphate is going to exist more in the dihydrogen phosphate form. If the pH is alkaline, on the other hand, the quantity of dihydrogen phosphate will decrease and phosphate is going to exist more so in the dibasic phosphate form. So phosphate concentration is not that much constant. However, if you take them together, both the phosphate forms, it is about 3 to 4 milligram per deciliter, and around this value, the phosphate concentration is maintained. Now, altered phosphate levels, they do not have many immediate effects. Unlike the calcium levels, even slightly altered calcium can cause extreme immediate physiological effects. Now, let's look at the two scenarios which can exist pertaining to calcium. In the case of hypocalcemia, what actually happens is that there is increased neuronal membrane permeability to sodium, as you must remember from the nerve and muscle physiology. So, in the presence of this increased neuronal membrane permeability to sodium, when there is hypocalcemia, the excitability of the neurons, it increases markedly. Because of that, there is spontaneous discharge of the nerves, and repetitive nerve impulses to peripheral skeletal muscles are going to result in a condition which is known as tetanic muscle contraction. Now, this tetanic muscle contraction is quite dangerous if it develops in the laryngeal muscles, for example, which are prone to develop it. It is going to cause airway or respiratory obstruction. This increased excitability can also predispose an individual to seizures, dilation of the heart, and impaired blood clotting because calcium is required for blood clotting mechanisms. On the other hand, if hypercalcemia occurs, it is going to cause CNS depression. It also may decrease the QT interval, predisposing an individual to arrhythmias. And there are certain other symptoms which include lack of appetite and constipation. So these are some of the signs and symptoms which can be found in the presence of hypocalcemia and hypercalcemia, and they reiterate the importance of regulating this iron to the very narrow range. Now let's discuss the calcium balance. We have seen that extracellular fluid, it contains less than 0.1% of calcium. The 0.1% of calcium is maintained by the calcium intake from the bones, and then there is an interchange between the cellular and extracellular fluid calcium, interchange between the bone and the extracellular fluid calcium, and the calcium which is obtained from the food sources, it is absorbed in the gut and is being made available to these compartments. So let's start from over here. Calcium intake, it usually is about 1000 milligrams per day. Out of this 1000 milligrams per day, only 350 milligrams per day is absorbed in the gut, while rest of the calcium that was in the food is excreted in the feces. Now, this calcium, when it is absorbed in the extracellular fluid, it is filtered into the kidneys, and in the kidneys, almost all of the filtered calcium is actually reabsorbed. Only 10 milligrams per day is excreted in the urine. Now, this extracellular fluid calcium, 500 of it milligram per day is actually deposited in the bones, and then this calcium can also be withdrawn from the bones, or process refers to resorption, which is about 500 milligrams per day. So you can see right over here, the bone contains a huge quantity of calcium, and the daily intake of calcium out of that 500 milligrams per day from the extracellular fluid ends up getting deposited in the bone, and the deposition and reabsorption is maintained by some factors which include both the hormonal and some other factors to maintain the ECF fluid calcium. It is pertinent to look at the bone physiology if we are going to discuss the calcium and phosphate balance in the body. The bone is composed of organic matrix and calcium salts. Calcium salts, they form 70% of the total bone mass, whereas the organic matrix, which is composed of proteins, especially collagen, it forms 30% of the total bone mass. So collagen and hydroxyapatite crystals, they constitute the bone. Increase in the interstitial fluid concentration of calcium or phosphate, and when they are together, even more so, there is going to be promotion of bone mineralization. Bone mineralization refers to the deposition of calcium salts in the form of these crystals and association of these calcium salts with the organic matrix itself. If there is decrease in the interstitial concentration of calcium and phosphate, it is going to result in resorption of these salts from the bone. That is, these salts are then going to be removed from the bone. This process is known as demineralization. So mineralization of the bone and demineralization of the bone, it actually depends upon the product of calcium and phosphate in the ECF. If there is increased concentration in the interstitial fluid of these ions, then bone mineralization is going to take place. If the concentration of these ions decreases, even the concentration of the phosphate alone decreases or the calcium ion alone decreases, it is going to cause resorption of these salts from the bone, that is demineralization. So the calcium crystals which are bound to collagen fibers, they impart strength to the bone, and calcium salts, they are responsible for the compressional strength of the bone. Now we are looking at the deposition of these crystals or precipitations of these crystals in the bone. Why don't these crystals precipitate in the rest of the cells? Even in the bone and in the rest of the tissues, there is a protein known as pyrophosphate, which actually prevents precipitation of hydroxyapatite crystals. So whenever mineralization of bone is going to take place, this pyrophosphate is going to be inhibited, and then mineralization in the bone will be taking place. And in the rest of the tissue, this pyrophosphate is active and it is preventing the precipitation of hydroxyapatite crystals. Now let's look at the mechanism of bone calcification. So there are two types of bone in the body, cortical bone and the trabecular bone. Cortical bone is about 80% of the bones are cortical bones and the rest are trabecular bones. So how is bone actually laid out? There are cells which are known as osteoblasts. These cells are responsible for laying down osteoid. Osteoid is the bone substance which is composed of collagen plus ground substance along with the osteocytes. These osteocytes are actually osteoblasts, which have now they performed their functions and they are now going silent. So when the osteoblasts they go silent, they become osteocytes. So osteoid contains collagen, ground substance, and osteocytes. Then when this osteoid is formed, calcium salts, these are precipitated in the osteoid, and where they are converted to hydroxyapatite crystals. Some of the calcium, it remains in the amorphous form, and this forms the exchangeable calcium pool. This exchangeable calcium pool, it is involved in the rapid shift of calcium between the compartments, between the ECF and this bone compartment, and it does not involve the osteolytic activity of the bone. That is, bone is not actually broken down when the calcium is being removed from this pool. We are going to see the importance of this subsequently. So now this is the osteon. It is characterized by this lacunae present between these. In the center of this osteon lies the Haversian canal. Now we have seen that osteoblasts, they promote the formation of osteoid. They actually form the osteoid, and for the bone to form the pyrophosphate, which actually inhibits crystallization and calcification of the bone, it has to be inhibited. So osteoblasts, they form another protein to inhibit the pyrophosphate. This protein is known as tissue non-specific alkaline phosphatase, or TNAP. TNAP stands for, it is an acronym for tissue non-specific alkaline phosphatase. This protein is expressed by synthesized by osteoblasts, and when bone mineralization or crystallization has to take place, it is expressed by the osteoblasts, and this ends up inhibiting the pyrophosphate. So when the bone mineralization or crystallization has to be regulated in the opposite end, that it has to be stopped. Two other proteins are expressed by the osteoblasts. These proteins are NPP1, which stands for nucleotide pyrophosphatase phosphodiesterase 1, and another protein which is known as ankylosis protein 1, or ANK. So these two proteins, if they are expressed by the osteoblasts, they actually stimulate the synthesis of pyrophosphate, or they are responsible for activation of pyrophosphate, because of which the inhibition of crystallization and calcification of bone will take place. So this is how the bone mineralization is promoted via production of TNAP by the osteoblasts, and it is inhibited by the expression or production of the other two proteins, NBP1 and ANK. Now, bone is undergoing constant remodeling. This remodeling is more common when a person is growing up, and there is increase in the bone length, that is during the time of growth and around puberty. However, the bone is also constantly undergoing remodeling in other conditions, when it is exposed to stress. As response to mechanical stress, it is going to remodeling. When the bone material is getting weaker, the bone is remodeled again. So this remodeling actually occurs by the specialized cells, which are known as osteoblasts and some other precursors. So there is a balance between the bone remodeling and prevention of decrease in bone mass. Whenever there is going to be bone breakdown, the bone mass is going to decrease, and where the breakdown has occurred, new bone is going to be deposited. This is known as bone remodeling. So what are the factors which are involved in these two states? So osteoblasts and their precursors, they secrete a ligand, a protein which is known as rank ligand or rank L. Now we are looking at the bone resorption or bone breakdown first, that how exactly is the bone broken down. So when the bone has to be broken down, osteoblasts, they secrete a protein which is known as rank ligand. Obviously, it is a ligand, so it is going to have a receptor somewhere. The receptor for rank ligand is found on the macrophages and osteoclasts. So now there is another population of cells which are known as osteoclasts. These cells are responsible for resorption and breaking down of the bone. So these cells, along with the macrophages, they express a receptor which is known as rank. So rank is the receptor present on the osteoclast, and the rank ligand is synthesized by the osteoblast. If they secrete this rank ligand, it binds with the rank receptor, and when this binding it takes place, it triggers the two processes which are known as differentiation of macrophages into osteoclasts. The macrophages to which the rank ligand had bound, they will be differentiated into osteoclasts, and the osteoclast receptor to which the rank ligand had bound. Now, these osteoclasts, they are not going to undergo apoptosis, they are going to persist. So the suppression of osteoclast apoptosis occurs, and the differentiation of macrophages into osteoclasts is promoted. Because of these two effects, the osteoclastic action is increased. Osteoclast action outpaces osteoblast action in this case, that is, new bone is not being laid down. However, the osteoclastic activity is actually increased and the bone is broken down. The result will be decrease in bone mass. On the other hand, if the osteoblasts, they are secreting osteoprotein. Osteoprotein is an other protein which covers up or which binds with the rank ligand. When the osteoprotein, it covers or binds with the rank ligand, it is not able to bind with the rank receptors. So this osteoprotein is a protective protein against the bone breakdown. What it does, it covers up or it binds with the rank ligand. So the rank ligand, it cannot bind with the rank receptors. When the rank ligand, it does not bind with the rank receptors, the macrophages, they are not differentiated into osteoclasts, and the osteoclasts which were already present, they undergo apoptosis because it is not suppressed. So the blockage of action of rank. So the osteoclast action is now decreased and osteoblast action outpaces osteoclast action. So the bone mass is actually increased as bone will be laid down and not broken down. Now there are certain hormones which can influence this pathway. For example, estrogen. Estrogen promotes the synthesis of osteoproteins, so it helps prevention of the decrease in bone mass. Decreased activity of osteoclasts results as the synthesis of osteoprotectin is increased. That is why after menopause, when the estrogen levels are decreased, what happens is that these individuals, these women are prone to develop osteoporosis, which is characterized by the increased breaking down of bone and bone demineralization, which results in multiple fractures. On the other hand, glucocorticoids, they increase the synthesis of rank ligand and decrease the production of osteoprotectin. They act on the osteoblasts and they act by decreasing the rank L production and by increasing the rank ligand production and decreasing the osteoprotectin production by the osteoblasts. So there is increased osteoclastic activity as a result. So the bone is continuously undergoing remodeling, especially weight-bearing mechanical stress. It is going to cause the remodeling of bone and it requires increased mineralization of bone. So this is the importance of bone remodeling in day-to-day life. Now that we have discussed the distribution of calcium and phosphate in the body fluid compartments and we have looked into a little bit of detail of bone physiology, let's discuss the hormonal regulation of calcium and phosphate. We'll begin by discussing the functions of parathyroid hormone. So parathyroid hormone is secreted from the chief cells of parathyroid glands. These glands are located at the posterior poles of the thyroid gland. There are 4 in number. They secrete a polypeptide hormone, which is known as parathyroid hormone or parathormone. This parathormone is released in response to decreased free calcium levels, and its actions are mediated through the cyclic AMP. So what exactly are effects of parathormone or parathyroid hormone? This hormone, it increases the calcium reabsorption in distal tubule of the kidney. It inhibits the phosphate reabsorption in proximal tubule of the kidney. So it is promoting calcium reabsorption in the kidney while it is inhibiting the reabsorption of phosphate in the proximal tubule. It also stimulates the 1-alpha hydroxylase enzyme in the kidney, which is responsible for activation of vitamin D. So by activating that enzyme or stimulating that enzyme, it is actually promoting the formation of active form of vitamin D. It also causes bone resorption. So parathyroid hormone, because it is released in response to decreased plasma calcium levels, so it is going to do everything to increase those levels back to normal. It brings that about by increasing the calcium reabsorption in the distal tubule of the kidney, by activating the vitamin D, and by causing bone resorption, which releases calcium and phosphate into the blood. It also increases intestinal absorption of calcium and phosphate. However, this effect is mediated by vitamin D. But parathyroid hormone is actually promoting the conversion of inactive vitamin D to active form. So indirectly, it is also involved in the increased intestinal absorption of calcium and phosphate. Parathyroid hormone causes mobilization of calcium and phosphate from bone. It brings about these 2 actions in 2 phases. There is a fast exchange element and then there is a slow exchange. Fast exchange occurs from the osteocytic osteoblastic bone membrane. The fast exchange occurs through this membrane. This membrane actually separates the mineralized bone compartment from the bone fluid. This bone fluid compartment contains the amorphous form of calcium and phosphate, from where these calcium and phosphate can readily be moved into the plasma. So this osteocytic and osteoblastic membrane, it contains a specialized calcium pump, which is activated in the presence of parathyroid hormone. When the parathyroid hormone stimulates this pump, there is the fast exchange of calcium from this labile pool towards the plasma. The slow exchange involves the formation of rank ligand from the osteoblastic cells, which then cause the osteolytic activity through the osteoclast. So the rapid phase is characterized by activation of calcium pump in the osteoblasts and osteocytes at this osteocytic osteoblastic bone membrane. This will bring about osteolysis. This osteolysis, it does not involve resorption of actual bone and gel matrix. Slow phase is brought about by stimulation of the osteoblast to release rank L ligand, which is then going to increase the osteoclastic activity by binding to the rank receptor. So how parathyroid hormone is regulated? The release of parathyroid hormone from the glands is stimulated by decreased free calcium levels. Whenever the free calcium levels are low in the plasma, the parathyroid glands will be stimulated and parathormone will be released. It is also released in increased calcium requirement states, that is, during pregnancy, lactation, and when the bone growth is taking place around puberty, for example. It is actually seen that the parathyroid glands are a bit enlarged during pregnancy and lactation. Increased phosphate levels, they also increase the release of parathyroid hormone from the glands. What happens is that these phosphates, they bind with the ionized calcium, because of which the ionized calcium levels are decreased, which are then going to stimulate the release of parathyroid hormone. Increased magnesium also stimulates the release of parathyroid hormone, and it actually facilitates target responses of parathyroid hormone. The parathyroid hormone secretion is inhibited whenever there are increased free calcium levels in the plasma. These increased free calcium levels may be seen whenever there is excess quantities of calcium in the diet, increased vitamin D in the diet, or whenever there is bone resorption due to factors other than parathyroid hormone. This increased free calcium levels, they are sensed by calcium sensing receptors in the parathyroid cell membranes. These calcium sensing receptors, they respond by increasing the second messenger phospholipase C, inositol phosphate 3, and diacylglycerol. These second messengers, then they bring about the release of calcium from the intracellular stores, and this increased cytosolic calcium in the chief cells has a paradoxical effect, which is that in the presence of increased cytosolic calcium, instead of increased release of the hormone, there is in fact inhibition of release of parathyroid hormone. Vitamin D is another important hormone involved in the regulation of calcium and phosphate. There are two sources of vitamin D, the dietary source and that which is synthesized in the skin. These inactive forms of vitamin D3 and D2 and 7-dehydrocholesterol, these inactive forms of vitamin D have to be converted into an active form which is able to act on its receptors more efficiently. So 7-dehydrocholesterol synthesized in the skin, it is catalyzed by UV light to be converted into inactive vitamin D. The source of another source of inactive vitamin D is from the diet. This inactive vitamin D is converted into 25-hydroxycholecalciferol in the liver by the action of an enzyme which is known as 25-hydroxylase. This form of vitamin D, it is the main circulating form, but it has very low activity. It binds to the receptors, to vitamin D receptors less efficiently, and the effects are not seen that markedly. 25-hydroxy vitamin D is converted into the active form by the action of 1-alpha hydroxylase in the renal proximal tubule. Its activity is increased by low phosphate and by parathormone, and it is decreased by the active form of vitamin D3. So this is the negative feedback effect. The activity of this enzyme is increased by the parathyroid hormone, as we had seen earlier. Through the action of this enzyme, the active form of vitamin D3 is formed, which is known as calcitriol, and also 1,25-dihydroxycholecalciferol. This is the form of vitamin D, which is able to act on the receptors. Now let's review it over here. This in the skin, the cholecalciferol, vitamin D3, it has to be converted into 25-hydroxycholecalciferol. It is converted into this form in the liver. Then in the kidney, this enzyme, 1-alpha hydroxylase, which is stimulated by the parathyroid hormone, it is converted through the action of this enzyme into the active form of vitamin D, which is known as the 1,25-dihydroxycholecalciferol. Then this active form of vitamin D, it is going to bring about its actions, which include the increased synthesis of calcium binding protein in the intestine to promote the absorption of calcium from the gut. And it also activates the calcium-stimulated ATPases to further increase the intestinal absorption of calcium, and it also increases the alkaline phosphatase levels. All of these processes are actually involved to increase the intestinal absorption of calcium. Because of that, the plasma calcium ion concentration is going to increase. The plasma calcium ion concentration, when it increases, it is going to inhibit the parathyroid hormone. So this is the feedback regulation of the vitamin D synthesis. Receptors for active form of vitamin D, they are found in the nuclei of the target cells. These receptors are found in association or complexed with retinoid X receptors. And these retinoid X receptor and vitamin D complex, it binds to the DNA where it increases the transcription of proteins involved in the actions of vitamin D. Active form of vitamin D, it increases the absorption of calcium and phosphate by the intestinal mucosa by increasing the production of the calcium binding protein, calbindin, which promotes the absorption of calcium from the gut. High concentrations of calcium and phosphate in the extracellular fluid as a result is going to cause precipitation of bone salts into bone matrix. So vitamin D, it can induce both the mineralization and demineralization of the bone. When the vitamin D is able to increase the calcium and phosphate in the ECF, it is going to cause precipitation of bone salts into the bone matrix. That is, it is going to promote bone mineralization. It also enhances phosphate reabsorption from the kidneys. This effect is opposite to that of the parathyroid hormone, which was inhibiting the reabsorption of phosphate from the kidneys. In lower concentrations, the vitamin D, it promotes mineralization of the bone. However, in higher concentrations, it may actually cause bone resorption. Calcitonin is another hormone which is involved in the regulation of calcium. However, it exerts weak effects on calcium regulation. Why? Because the effect of calcitonin on calcium levels is that it is actually decreasing the plasma calcium levels. So whenever the plasma calcium levels will be decreased by the actions of calcitonin, the parathyroid hormone secretion will be stimulated and this effect will be nullified to some extent. So calcitonin is a peptide hormone secreted by the parafollicular cells of the thyroid gland. These parafollicular cells, they release calcitonin in response to increased free calcium levels. So calcitonin is involved in decreasing the free calcium levels. It is released in response to increased free calcium levels. It lowers plasma calcium levels by decreasing the activity of osteoclasts. So it decreases bone resorption. Calcitonin has a protective effect on the bone. To some extent, the importance of calcitonin or the significance of calcitonin is found in children where the bone resorption is prevented to encourage bone growth during pregnancy, in the Paget's disease in which there is increased osteoclastic activity, in the states of severe hypercalcemia, and in osteoporosis. So calcitonin has a weak effect. However, in these conditions specifically, the role of calcitonin cannot be undermined. Now let's summarize the hormonal regulation of calcium and phosphate. What has to be regulated are the plasma calcium and plasma phosphate levels. Let's identify the major hormones, which are parathyroid hormone. And then we have the 125 hydroxycholecalciferol, that is the active form of vitamin D. So let's see how these hormones are involved. So plasma calcium and plasma phosphate levels have to be regulated. Parathyroid hormone, whenever the plasma calcium levels are high, the release of parathyroid hormone from the glands will be inhibited. Parathyroid hormone, they increase the renal calcium reabsorption, they cause calcium mobilization from the bone. They stimulate the 1-hydroxylase in the kidney, because of which the vitamin D is converted into its active form. Parathyroid hormone, it inhibits the renal phosphate reabsorption, because of which the plasma phosphate levels will be decreased and more phosphate will be excreted in the urine. On the other hand, there are certain other hormones which are also involved. Cortisol, it causes increased calcium mobilization from the bone by increasing the osteoclastic activity, while estrogen, it inhibits the osteoclastic activity, because of which the calcium levels could be stabilized. So this is the summary of the hormonal regulation of calcium and phosphate. Discuss the abnormalities of these hormones. Abnormalities of calcitonin are rare, so we are going to focus on the parathyroid hormone and vitamin D. The primary hyperparathyroidism, as the name indicates, it involves the hypersecretion of parathyroid hormone because of the problems in the gland itself. This disease, the hyperparathyroidism, is characterized by increased plasma calcium levels, that is hypercalcemia. So the signs and symptoms of primary hyperparathyroidism are because of the increased calcium levels or hypercalcemia. So primary hypersecretion of parathyroid hormone is usually seen in the setting of adenoma, that is the tumors of parathyroid gland. These tumors are found more so in women because during pregnancy and lactation, the parathyroid glands are increased in size because of the increased requirement of calcium. This disease is characterized by such features as polyuria. The polyuria, it occurs because hypercalcemia, it interferes with the actions of ADH and it actually can cause nephrogenic diabetes insipidus. Hypercalciuria occurs because of the increased concentration of calcium in the urine, which is present because of the increased calcium in the plasma. And then because of the parathyroid hormone's effect on the osteoclastic activity, there is decreased bone mass. Constipation may also be found in these patients because of the hypercalcemia, which decreases GI motility, and because of that, they may present with abdominal pain. They are predisposed to develop peptic ulcer, and they may also present with lack of appetite. Hypercalcemia causes depression of CNS and peripheral nervous system, and the individual is predisposed to develop cardiac arrhythmias because of the decreased QT interval, which is seen in hypercalcemia. Because of this hypercalcemia, there may be metastatic calcification in tissues. Now, this excess calcium can precipitate in the tissues, especially when the free calcium levels they exceed more than 17 milligrams per deciliter. This calcification is seen in the alveoli, stomach, kidneys, and thyroid gland especially. And because of this metastatic calcification, the functions of these structures is compromised. So primary hyperparathyroidism, it presents with such symptoms, and they can be remembered with the mnemonic, which is known as bones, moans, stones, and psychiatric overtones. It basically indicates the involvement of systems. So bones are fragile because of their increased demineralizations. Moans is due to abdominal pain, for example, or the ureteric colic because of the stones in the kidneys. So stones can be formed because of the hypercalciuria. Psychiatric overtones indicate the involvement of CNS because there is depression of CNS. These patients, they may present with symptoms of depression as well, or psychosis. Abnormalities in bone are seen in hyperparathyroidism because of increased osteoclastic activity, which may manifest as extensive decalcification and large punched out cystic areas of the bone, which are filled with osteoclasts. These osteoclasts, they clump together, forming giant cells, osteoclasts, which may even resemble some tumors, which actually these cells are not neoplastic, but they clump together and they resemble the tumors. These large punched out cystic areas of the bone, these findings, they are together called osteitis fibrosa cystica. This is the characteristic finding of the hyperparathyroidism. These individuals, they are prone to develop multiple fractures. The bone profile in hyperparathyroidism is characterized by increased plasma calcium levels, decreased phosphate, because the parathyroid hormone, it actually promotes excretion of phosphates in the urine by decreasing their reabsorption. And then there are obviously increased parathyroid hormone levels and increased alkaline phosphatase levels. Increased alkaline phosphatase levels are seen because of the increased osteoclastic activity. The osteoblast will try to lay out new bone, and the alkaline phosphatase is the marker of osteoblastic activity. The secondary hyperparathyroidism, as its name indicates, the hyperparathyroidism in this case is secondary to decreased plasma calcium levels, which stimulate the release of parathyroid hormones from the glands. So high levels of parathyroid hormone occur as a compensation for hypocalcemia rather than as a primary abnormality of the parathyroid glands. They can be caused by either vitamin D deficiency or chronic renal disease. In the chronic renal disease, the vitamin D is not converted into its active form, so there is hypocalcemia as a result, which stimulates the release of parathyroid hormone from the gland, and it may result in secondary hyperparathyroidism. So the bone profile will reveal decreased calcium levels along with increased parathyroid hormones levels. So this is how you can differentiate between primary and secondary hyperparathyroidism. In primary hyperparathyroidism, hypercalcemia along with hyperparathyroidism will be seen. However, in secondary hyperparathyroidism, hypocalcemia along with hyperparathyroidism will be seen. In hypoparathyroidism, it could be hereditary or autoimmune in nature, or it could develop following the thyroid surgery in which parathyroid glands may be accidentally removed. It is characterized by inadequate secretion of parathyroid hormone by the parathyroid glands, because of which there is going to be decreased plasma calcium levels and increased phosphate levels. Hypocalcemia is recognized by the presence of tetany, and laryngeal muscles are susceptible to this tetanic spasm, because of which respiration may be obstructed, and these individuals may die because of this. Vitamin D deficiency may manifest as rickets in children and osteomalacia in adults. It is characterized by abnormal mineralization of bone and cartilages. Rickets is seen before plate closure, while osteomalacia may develop after plate closure. That is why rickets is found in children and osteomalacia in adults. It is characterized by expansion of the epiphyseal plates, and the most striking abnormalities are the bowing of the legs, as you can see in this picture, pain, poor growth, and soft bones in the children. Symptoms are more subtle in osteomalacia. Most common cause in adults is a malabsorption disorder, that is celiac disease, for example. Osteomalacia, it occurs usually when there is poor absorption of calcium from the gut, usually in the setting of any malabsorption disorder. Or vitamin D deficiency may also result in osteomalacia in the adults, especially in prolonged kidney damage, which is also known as renal rickets. When this vitamin D deficiency occurs in response to prolonged kidney damage in which vitamin D is not activated, so it is known as renal rickets. With that, we conclude our today's lecture. These are the study resources which were used to make these lecture slides, and you can use them to study on your own. If you have any questions, please drop them on any of our social media handles. Thank you.